So it's a real privilege to be back here. I think this is the 4th year now that I've been to Exponential Medicine, and I'm always inspired and get an injection of sort of can-do attitude from not just the speakers. And wasn't young Olivia yesterday just breathtaking at 18 years old? Totally inspiring, but some of the startups in the Innovation Lab and some of the talks. So it is a real privilege to be here to tell you about some of the things we're doing in the National Health Service in England. So I was here a year ago, and I thought I'd give you an update on some of the things, but also just refresh some of the things about the NHS and what we do. So the size and the scale of the organisation I work in makes it the largest single healthcare provider on our planet. We serve a population of just over 54 million people, and each year we spend around about £110 billion on their healthcare. We have just over 150 acute hospital trusts and just under 8,000 primary care centres and GP practices in our country. Now, when the NHS was founded 68 years ago, since that date, our population live on average 15 years longer than they did then, with an average life expectancy of just under 80 years for men and 82 for women at the moment. We are the 5th largest employer on the planet, with 1.3 million employees in our service. And every 36 hours, we see another 1 million patients through the system. We see 75 million outpatients, 23 million emergency room visits, and 16 million inpatients visits a year. So people say, God, that's such a big system, it must be really difficult to do anything in and make any change. And I understand that, but actually that's an advantage too. Because if you want to innovate at scale, I would argue that the NHS is the place on the planet where you can do that. So we face a number of challenges in England, and they're faced here in America, they're faced all across the world. And it's not just an aging population living longer with their chronic diseases. They get acute conditions and diseases on top of that, but things have changed. So of our 110 billion spend, 70% of that now goes on chronic disease management. Yet the system we designed 70 years ago was based around acute care. So around 2 years ago now, the NHS came out with the vision of how are we going to tackle the grand challenges and the problems we face? How can we remain true to our aims as delivering a high quality healthcare system free at the point of delivery for generations to come? So we published this document, the 5-year forward view, which looked at 3 core things, which we well know: the triple aim, better health, better care, delivered more cost effectively, and efficiency. So in the first one, looking at the health and well-being gap, we've heard numerous speakers speak about prevention, how we need to move from a sickness model of care to a wellness model of care. It's a disruptive innovation. It's a new marketplace. How can we do that? So we've launched a number of programs with our partners at Public Health England. We're looking to how we can use incentives in levers in the way we purchase things in the NHS. And earlier this year, our Chancellor of the Exchequer announced a sugar tax on soft drinks that are going to come out, and there are a number of other policy areas that we're going to take forward with those. So the figures in England are around 20% of our population smoke, around 1/3 of people drink too much alcohol, and about 2/3 of people are either overweight or obese. So these are all preventable lifestyle things. So how can we engage with our population so that these things which are entirely preventable can allow us to deliver the care we really need to? So in the care and quality gap, we have over 50 vanguard sites where we've taken populations of hospitals and primary care centres, and we've put them together, and they bid to where their particular area of specialty was. We call them the vanguard sites, to say we can pioneer and lead these new models of care for you, whether it is developing smart care homes and technology for people's homes that can help them live happier, healthier, longer lives more independently, whether it's redesigning our primary and secondary care services so that more like accountable care organisations, so primary, secondary and social care work together, so that hospital chains work together and collaborate to take things forward, and completely redesigning the way we do emergency care. And then, of course, lastly, we have a funding gap in the NHS. We've identified around £30 billion of savings we need to make by 2020 if we're going to stay at the same level we are now. So more of the same isn't going to do that. We're not going to get there by just carrying on doing what we've always done. We have to do something differently. So all that is going on in the NHS. And we've heard a number of speakers say at the first 2 days already that personalised medicine is really coming on, and that's going to be empowered where patients are more in charge of their healthcare than they've ever been before. So this one-size-fits-all approach that we used to have to medicine, now that's just not personalised medicine in terms of genomics. It's all these other things. It's how do we create a personalised system around individuals that bring on board the technology, or the artificial intelligence and the digital and mHealth platforms, but also how do people feel more socially included? As people get older, their social networks break down, so we have to have at the heart of our system not just patients because they're already sick, but as John Mattison said, I think in his talk yesterday, we need a healthcare system designed around our people, not just patients. So all that's going on with the 5-year forward view, we've got this going on. So what are we going to do to address that? And we see so many great things here. If you've been over to the Innovation Lab, and I've been coming here for 4 years now, and many things have come and gone, and not many of them in the 4 years I've been here have actually been taken up and disrupted and are now used at scale across the system. So why is that? Well, I love this quote from John Maynard Keynes, who was a British economist, and in his book in 1935, I think he describes the problem where he says, the difficulty lies not in the new ideas, but in escaping from the old ones, which ramify, for those of us brought up as most of us have been, into every corner of our minds. Now that's medical custom and practice. That's the apprenticeship as a practicing surgeon that I was brought up with. And that's the thing that is most difficult to change. It's not the great new ideas and exciting one. It's us stopping doing the old things that once served us well, but now don't serve us so well anymore. So I thought I'd give you an example. One of the great privileges I have at NHS England, because we're the largest unified healthcare system on the planet, is the world beats its way to the door of the NHS. I think from every continent virtually we've had people come and see us with their latest, greatest ideas. So in the 2 years I've been in post at NHS England, I've seen over 1,000 companies come and pitch to me with some of their latest, greatest ideas. And it struck me when I saw all those that actually doctors aren't changing a great deal, and I thought I'd capture it in this slide, which looks at the doctor's bag, which is what all doctors have. And if you go back to ancient Egypt, 5,000 years ago, you can see in the hieroglyphics, there were scrapers and cutters and graspers and gouges that they used. And then when I was researching this, I found the image next to it, which is almost identical from Arab texts in the Middle Ages. 4,500 years. What's the difference between those two slides? Almost nothing. And then from the Wellcome collection in London 100 years ago, in 1920, well, in the doctor's bag now, we've added a stethoscope, which has been invented, and a sphygmomanometer. But outside of that, very little else has changed. All the same cutters and graspers that we used to have. And then up as recently as 2000, still a very analog doctor's bag. We've added some alcohol gel and some disposable gloves now, but outside of that, it's still the same as it was 5,000 years ago, largely. So this is the custom and practice. So doctors haven't changed. So what's come along? What is impacting our lives more? When you look at, are the latest, greatest things coming out of our hospitals and out of our universities, or are they coming out of companies? Are they coming out of startups? Are they being disruptive? And if you look at Uber, Airbnb, Google, Microsoft, Amazon, how they are changing our lives day in, day out. So technology could. So I think the doctor's bag actually should be resigned to the last century and millennium, and it doesn't exist anymore. And what I see patients coming to me with is what I would call a digital patient kit. Much of the technology on this slide you'll have seen through this week already, although there'll be one or two things you probably haven't seen before. But this kit is now available to our patients, so more technology available here than is present in most primary care centres and doctors' facilities in our country. Whether it's smartphone plugins that you take in, many of them we've seen, but all sorts of glucometers and dermatoscopes and the AliveCore, which we heard about earlier. Connected devices, the CliniCloud. 2 Australian junior doctors said, why can't we just have a little Wi-Fi disc that acts as a stethoscope, and they've created an algorithm that is more sensitive and specific at diagnosing pneumonia than the average clinician listening to someone's chest. So we can now disrupt that down into the care home. On the platforms and condition-specific apps, there are lots of really great ones. MyM Health is a great chronic disease management platform that we've been supporting through our National Innovation Accelerator program. But the one that has taken my breath away in the last year when they came to see me was Cordio, which is a little startup from Israel. Now, this is an app that runs in the background on your mobile phone, and it listens to changes in the tone of your voice as you speak. That's all it does. Their first study has been done in congestive heart failure, and they were able to predict up to 10 days in advance of an admission to hospital with an exacerbation of heart failure, that happening just from a change in tone in your voice when you speak on your phone. So you can ring your mum up, and she says she's feeling fine, and the app on your phone says she needs to take 20 milligrams more of her heart medicine to prevent an admission. Wow. There are all sorts of other things. I really like the Good Sleep Box from Optum because it's a combinatorial innovation. It's a replacement for sleeping tablets. It brings together an activity tracker, the Sleepio app, which is another one of our National Innovation Accelerator Fellows, and a call center so people can ring up. And for more than 60% of people using this, they're getting an average of an hour and a half to 2 hours more sleep a night rather than taking pharmacology. So how can we prescribe medicines to take these things forward? So, when we've heard earlier today about new designs in medical training and thinking, what medical school on our planet or what university trains its doctors or its clinical staff to deal with this empowered, personalized healthcare revolution that we're going into now? And the only place I know that covers everything is coming to Singularity University. And I think it's incredible. You see a cross-section of things, but this is just a conference. So, a year ago, I stood on this stage and I said NHS England had decided we were going to have a go at changing this, and we were going to launch the world's largest clinical entrepreneur training program. We reckon the latest, greatest things aren't always coming out of our hospitals or universities, and how could we equip our clinicians with the skills, the knowledge, and the experience from the startup world, from the commercial sector, to come and help us make the changes we need to transform healthcare. So the program consists of mentoring and coaching. They get a commercial coach to take them forward. They can do less than full-time training. We'll allow them to continue as surgeons or GPs or physicians and take 3 months or 6 months out or a day or two a week to learn to pursue their enterprise. A number of advanced internships with global corporates across the world, but also with startups and SMEs. But importantly, we're connecting them to people who want to buy those products and want those solutions, and also to the funding. And we have a range of education and network events going forward. Now, I think it was on this stage last year I said we're going live with our applications tomorrow, and we, from a small, I think 3 lines or 4 lines in the British Medical Journal, we had over 300 of expressions of interest from junior doctors applying to our program. And in September, a few weeks ago, we launched and announced our first year, so I've appointed 103 junior doctors to our program. Never before has a country at a national scale taken such a cohort and is going to incubate them for a whole year to see what can happen and come out of that. Now, rather than try and show you a video or a list, I think we've got 7 or 8 of them who've come over to Exponential Medicine with me. I thought I'd bring a couple of them onto the stage so you can meet them to see the sort of young doctors we're bringing forward. Come forward. So we have young Harry here and Vishal. So why don't you introduce yourself, Harry? Tell us a little about you and where you are in medicine and your story and what had happened and what you're doing in the enterprise space, which I think is quite breathtaking.
Thank you, Tony. So yeah, I'm Harry Thirkessel, one of the first clinical entrepreneurs at NHS England. A year ago, I actually left the NHS. I was doing my surgical residency, and I was told in no uncertain terms that I had to choose between being an entrepreneur and completing my training. So I chose being an entrepreneur and left. Then I met Tony, and he introduced me to the Clinical Entrepreneur Fellowship. Now I'm able to go back and practice medicine, so I'm working as a resident in an emergency department in Harlow, and I do that part-time time, and I'm also able to sort of pursue my entrepreneurial ambitions. So I'm working with two companies. The first, I think Tony's already mentioned, is MyM Health, who have a self-management platform for chronic disease. Currently, they cover COPD, diabetes, and asthma, but I'm going to repurpose that platform and use it to revolutionize perioperative care. We're going to rehabilitate and optimize patients. And then the second company is also quite transformative, I'd like to think. It's called CareB&B, and it's a platform, absolutely, it's a platform which allows patients, relatives, and healthcare providers to access homes in the community which have unused disability modifications. So it's going to solve the problem of delayed discharge from hospital, and it's going to allow patients to recover in comfort close to home.
So thank you, Harry. So I think that's just stunning because we face a real problem. We can't have the public sector in England building more and more care homes, but actually there are lots of empty downstairs ground floor rooms that have already been converted for loved ones that their care needs have progressed, so they've had to move on. So they leave at home someone who's socially isolated and alone with this room that's already converted. Well, we can start socially connecting them again. It's almost fostering for the elderly. How can we get them into approved accommodation that's there in the community and start integrating people? And I think that could be really disruptive for the residential care market in our country. So Vishal, why don't you introduce yourself and tell us a little bit about the things you're doing and what you're doing on the Entrepreneur Program. But the other thing I should have said, the thing Harry demonstrates so nicely is in our country, 5% of doctors per year were leaving permanently to go and pursue another career, and about 50% of people, once they finish their foundation years, which is their second year of being a doctor, leave and go off and do something, many of them coming back, but lots of them not. In the United States, the figures from about a year ago at Stanford were up to a third of doctors were finishing medical school and just using it as a good degree to go and work in industry, and 20%, particularly on the west coast of the States, of some other universities were having the same thing. On the Clinical Entrepreneur Program, around 15% of the doctors who we've appointed are coming back into the National Health Service, having left it before. So we've turned a brain drain into a brain gain. There's no money, I'm not paying them to do this, they're entrepreneurs, they find their own funding and take things forward. What we've done is given them our permission and our blessing, something you're very good at in the United States here with supporting and encouraging your entrepreneurs, and we need to learn from that and support ours more. So that's a fantastic story. So Vishal, why don't you tell us a bit about yourself?
Hi there, I'm an anesthesiologist and I've just finished a PhD in medical machine learning, and I'm coming to the end of my 14-year residency. It's kind of usual when you've got other interests. So what I've done, I think, is really exciting. I've curated a data set of 1 billion blood results, and every single one of those is linked to diagnoses, procedures, and patient outcomes. Using this data, I've applied machine learning, and it's not just the stuff I've developed. I've basically taken almost every open source thing I can find and used it to model outcome. So what I can now do is the moment someone comes into hospital, I can predict whether they're going to live or die in the next 24, 48, or 72 hours. Not only that, but what do you do for those patients? For the patients who are likely to die, what is the next test? What is the next procedure they should have? We built the models. They work, and they're currently under peer review. But creating these models isn't enough. They'll just be a journal article. 10 years, 20 years from now, they won't be applied. So we also developed a platform that allows these models and anything else anyone develops to be applied in real time in any Western hospital in the world. It doesn't matter what your incumbent IT vendor is. It works on standard messaging platforms and does real-time analytics. It's kind of like an algorithmic trading platform for medicine, but with a lot of morals and ethics and governance attached. What the Clinical Entrepreneurship Program's providing is it's providing that insight into how providers, payers, patients all come together and how you link this in. So locally in the NHS, with Tony's help and the rest of the NHS England team, we're trialing this in a few hospitals, and internationally, I think it's got the potential to disrupt patient pathways and acute care.
So you can see I have trouble keeping them quiet, and this is 2 of 103 young doctors that I have who are all equally stunning. When you put them together in the room as a cohort, it's like fireworks displays going off. It is incredible. They're bouncing off each other with all the ideas. We now need to mix them in with the rest of the communities for the CEOs, for the CFOs, for the CIOs and others coming forward. The link for the Clinical Entrepreneur Program, if you want to have a look at it, is up there on the screen, and we're looking for partners, we're looking for people to help us, and it doesn't matter if you're not in England. We've had a number of governments approach us from abroad saying, we'd love to do something similar, come and work with us. Thanks very much for your time and have a great conference.